So I am super excited to chat with Dr. Brian Plante as we are going to be talking about vector-borne infections, including Borrelia, Bartonella, Babesia. And so let me go ahead and give Dr. Plante's impressive bio here, as he is a licensed naturopathic doctor with extensive training in integrative whole person healthcare approaches. He works closely with those suffering from complex immune dysfunction, including Lyme disease, chronic viral infections, environmental toxicities such as mold illness and heavy metal toxicity, autoimmune disease, mast cell activation syndrome, fibromyalgia, and chronic fatigue syndrome, myalgic encephalomyelitis. Through compassionate listening, detailed instruction, and a commitment to helping patients see lasting change in their lives, he hopes that his presence will leave each person feeling deeply supported through their journey to optimal health. And thanks so much for joining us, Dr. Plant.
Thanks so much for having me.
Yeah, just really looking forward to having this conversation about vector-borne infections with an emphasis on Lyme disease, Bartonella, as well as Babesia. And so before we do that, can you give a little bit of your background? How did you start focusing on, I mean, you focus on a lot of like complex conditions, not just the vector-borne illness, but mold toxicity. So how did you start down this path?
Yeah, so I was always really interested in some of the more challenging cases where you kind of have to think like a detective and put all the pieces together. And then when I did my residency at a naturopathic clinic in the Sacramento area a few years ago, I saw a lot of tick-borne infections and a lot of mold toxicity. And I don't think I had realized, being in school in Portland, Oregon, just how prevalent it was in California. Particularly Northern California and the Bay Area. So part of it arose from an aptitude and desire to work with more complex cases, but a big part of it came from the demand. There was just such a need in that area geographically, and there weren't very many of us. And so the doc that I trained with, Dr. Jamie Kunkel, taught me most, if not everything that he knew about it. And I felt like I got about 5 years of education in about a year and a half. And then it just kind of took off from there because of the like I said, the need for support with those conditions.
All right. Well, thanks for sharing that. And how common are vector-borne infections? Because some people get the impression they're only common in certain areas, like, for example, the Northeast, but other areas, they're not as common. Do you see them pretty much everywhere? Like, I don't know if you work with people remotely. So if you have an opportunity to work with people like in different states, and if you see them being widespread, or if you consult with colleagues who say, yeah, it doesn't really make a difference where the person is, they're susceptible to getting these infections.
Yeah, so I do work remotely and do get some of that, kind of firsthand. I don't necessarily want to call it data, but exposure. But they are a lot more prevalent than people realize, including in places where previously we didn't see a high prevalence. So certainly there are places in the country where it is much higher, incidence and prevalence, particularly the East Coast. Where we're working with cases like that, it's not uncommon for folks to have had 2, 3, or more exposures to an infection, and the cases tend to be a lot more severe in their acute presentation. But even in Southern California, I've seen cases of Lyme, and the ticks that are endemic to this area are not well known to be carriers of Lyme. So we're kind of scratching our heads a little bit about that. I've also seen cases in Arizona where it wasn't as suspected to be as common, but I'm always asking about tick bite exposures as well as fleas and other biting insects, cats and dogs, because I still think there's a lot we don't know about just how these organisms can be transmitted. And I suspect they're a lot more prevalent than we realize. It is important, though, I think, to delineate between a Lyme infection, maybe where you have the organism, and Lyme disease, where there's a lot of observable symptoms and more increased need for treatment. So I still think there's a lot of debate on just how common these organisms are, and to what extent do we really need to be screening for them and treating for them in patients with a variety of chronic degenerative conditions.
So one of the questions I was going to ask is, can there be vectors other than ticks? And it looks like you answered that because you mentioned fleas. I don't know if mosquitoes could also transmit. I think there's some controversy over that. But would you say ticks are the most common, or is it something that we just don't know?
Yeah, it's a good question. So for Lyme, ticks are the black-legged ticks, both on the Pacific side and on the East Coast. Sorry, I'm not remembering the exact species names. Are the primary vector for Lyme. But with Bartonella, it's actually cats and fleas that are more common transmission vectors than the ticks. And we can talk in more detail about that if we like. But the jury is still out on mosquitoes. I wonder about babesia because it behaves a lot like malaria. And there's been instances where I've had people with babesia with no other known animal or insect exposures, and their mother didn't have it, so it wasn't like they were born with it. The ones that are really leading the research on zoonotic or vector-borne infections are the veterinarians, particularly in the Bartonella landscape. So I still think, unfortunately, that there's a lot we don't know as a medical community, and even in the veterinary community, about just how these organisms can be transmitted.
Yeah, I was diagnosed with chronic Lyme disease in 2018, and I was not only not only did I test positive for Lyme, but also Bartonella, and there was no evidence of a tick bite. So I don't know that just because there's no evidence doesn't mean I wasn't bit by a tick, but it makes me wonder, could fleas possibly be a sore? I assume it was the same, whether it's a flea or a tick, but it sounds like with Lyme, there's a greater chance of ticks. Is there any evidence of fleas with Lyme, or is it pretty much ticks with Lyme, and then with Bartonella and Babesia, maybe? Well,
I
Babesia, not
haven't.
sure, but
Yeah, I haven't heard specifically about fleas with Lyme disease. I'd have to do a more updated literature review on that and see if there's anything newer out. The statistic that's most recent that I heard was about 30% of people living in the United States with Lyme disease never recall having had a tick bite. I suspect that's underreported. And of course, there's questions about tick size, particularly the young ones, the young ticks, about whether we did actually get a bite but didn't see it, or if there's other animal and insect vectors, and it's probably a little bit of both.
for those who have gotten bit by a tick, and if they know they got bit right away, like how soon? Obviously, the sooner you act, the better. But let's say if it's some sources, I think, say within 3 days, but then others say it could be within a few hours as far as the transmission of someone getting Lyme or, let's say, Bartonella.
Yeah, so we used to think that the tick attachment time, like how long it was embedded before it was removed, was a significant determinant of the risk of transmission. But some of the newer data has questioned that, and suggested that it doesn't really matter how long the tick has been attached, because I've had people say, "Oh, it was only attached for a few hours, but we did have to remove it with tweezers." Excuse me. I still recommend sending off the tick to be tested, as well as testing the person either for antibodies, although there can be issues with that test, in terms of how quickly we're going to see those responses. But it's very common to do some sort of empiric therapy or treating as if early if there's suspicion. But there doesn't seem to be a clear association anymore with how long the tick was attached.
Do you have a favorite lab that you send ticks to, like that you would recommend for a patient to send it
Yeah,
to?
I thought you were going to ask me that, and I just remembered that I think University of Massachusetts for a while had one. Tick, I wish. Sorry, I should have looked that one up before this, but I haven't had to do it in a while, to be honest. I don't see a lot of acute cases, at least where I'm located. But I can certainly give, if you have a resource page that you provide to the episode, I can give you an updated list after this.
Yeah, that'd be great. Yeah, I could just put it in the show notes, so that would be wonderful. What I think also, I don't know if you're familiar with medical diagnostic laboratories that
Mhm.
they do some testing for the tick-borne or vector-borne infections, and I think they also look at the tick too. I don't know. I don't know if these other places are free, because I know they I'm pretty sure they charge to like evaluate the tick, but
I think so.
um, yeah.
Yeah.
Okay. How about symptoms? What are some of the common signs and symptoms. And I know there could be a lot of them. So I guess not to focus on all of them, but I guess some of the more common ones. And then if there are differentiating factors, like I do know, like with babesia, like night sweats, I think are like common, so that's like maybe one differentiating factor. But if you could dive a little bit deeper.
Yeah, so there is a lot of overlap. There also can be some variation between acute presentations or new infection versus chronic or long-standing, well-established infection. So with Lyme disease, we kind of see the hallmark summer flu symptoms in the sense of feeling, flu-like headaches, fatigue, brain fog, muscle aches, or joint pain. We tend to see a lot more joint pain, I would say, with Lyme than with the other ones, at least in my experience. With Bartonella, we can see more neurologic or neuropathic symptoms, numbness, tingling. I see a lot of foot pain with Bartonella, pain at the bottoms of your feet. That's because Bartonella infects the blood vessels. So anywhere where there's small blood vessels, if there's inflammation in those, we can see more unusual pain presentations. We can see headaches with Bartonella as well. But the hallmark, I think, for me anyway, with Bartonella is a lot of the psychiatric symptoms. We see a lot of irritability and rage, especially if folks have reported, parents or the patient themselves, I don't feel like it's me. It doesn't feel like it's really me. There's just this, I get overcome with this episodic rage and irritability. And that was one of the most eye-opening symptoms for me when I was in residency. I saw a few teens and young adults who presented, and they were quite irritable and difficult to work with. And then when we, did antibiotics and things like that, we started to see some improvement in their entire temperament, which was very eye-opening. With Babesia, the differentiating symptoms, I think, with Babesia are that the night sweats and the air hunger is a big one, feeling like you just can't get enough air in. That's because it's a protozoa or microscopic parasite that infects the red blood cells. So it can affect oxygen uptake at that level. We do tend to see, we can see fevers and chills with all of those. And then, of course, the classic a tick-borne relapsing fever, which is a type of Borrelia infection in the same genus as Lyme disease, but a different species. Actually, there are several species that can cause that, and we will tend to see relapsing fever, meaning you may have fever for a few days and then not for a while, and then it comes back. Babesia, we can see, Lyme and Babesia, we can see some psychiatric symptoms as well. But I often recommend testing for all three because there can be so much overlap. There can be times when you're like, this is for sure Babesia, and Babesia is negative and Bartonella is positive. And vice versa, where you think it's going to be Bartonella because it's a pediatric autoimmune neuropsychiatric or PANS case, and we end up finding that it's Babesia that's driving the neuroinflammation.
So you would recommend testing if you're going to test for Lyme and Bartonella, even if someone's not experiencing, let's say, the night sweats and air hunger, you still would recommend testing for Babesia?
If their budget allows, and cost is the biggest, barrier when it comes to some of the specialty, higher sensitivity testing. We could do a whole talk just on testing. There's not a perfect test, but ideally, yes, I would test for the big three. I might even, look for tick-borne relapsing fever or the rickettsias as well, which includes Rocky Mountain spotted fever, anaplasma, and Ehrlichia. I'm more concerned about those ones in the East Coast. Or with acute presentations than I am with chronic, but yeah.
Are you able to rank like the prevalence as far as like, what do you say, like Lyme is the number one vector-borne disease that you test for that comes back positive, and then like Bartonella second, or maybe Bartonella is number one?
So some of this is regionally dependent. At least according to current CDC statistics, Lyme is by far the most prevalent. But I think part of why I got so interested in Bartonella as a topic, and really kind of specializing and working with that in my time in the Sacramento area, is I was seeing actually quite a bit more Bartonella than Lyme in that region. That has not been the case in Southern California, where I've been for the last year. It also was less the case in the Bay Area, where I was practicing for a year as well in San Jose. And of course, we work with people all over the San Francisco Bay Area where tick-borne infections are well known to be prevalent, particularly Lyme. But I remember being surprised, thinking, Bartonella might actually, and even I think, I don't want to misquote him, but at the time, Dr. Kunkel was fairly convinced that Bartonella was as common or more common than Lyme. Babesia, we're seeing a lot more on the East Coast, but it is here as well on the West Coast and beyond. Part of that is also tick habitats are expanding. I mean, with climate change, we have longer seasons, so ticks are surviving the winters more. There's also a lot more transportations to regions that maybe they weren't in previously. So it's very difficult for us to say definitively just how prevalent these infections are, not to mention the issues with diagnostic testing.
Yeah. So in your practice, it sounds like, of course, you help with all of these, but you have more of a focus on Bartonella. So you're like, that's more of a specialty when it comes to these vector-borne infections.
Initially, but like I said, I'm seeing a lot less of it in the last couple of years, which I suppose is good that it's not present in this area. But I was fairly well trained in managing Bartonella in my first couple of years, and so it's thrown me for a loop a little bit. It's like, oh, okay, and what I'm finding is that I am needing to test for all three as a result, because I'm seeing the ones that I didn't expect to see, and I'm not seeing the ones, particularly Bartonella, that I was expecting to see.
So before I press record, I asked you if we could talk a little bit about disautonomia, POTS, because in some cases that is associated with these infections.
Yeah, I see it very frequently, as well as with long haul COVID. So what dysautonomia is a condition, any condition affecting the function of the autonomic nervous system, which is the automatic nervous system, the part that regulates non-voluntary functions like breathing, heart rate, blood pressure, temperature regulation. Those are the primary ones. And so, we can have a variety of mechanisms from these vector-borne infections that trigger dysautonomia. One is the actual direct infection of the vagus nerve by some of these organisms. That's been postulated as one theory of chronic Lyme, or differentiating between chronic Lyme as an infection and post-treatment Lyme disease syndrome, which is where you have all the same symptoms, you're just not responding as favorably to antibiotic therapy. And that is a damage or persistent infection can occur within the vagus nerve. I suspect that's a big part of what we're seeing with long haul COVID causing dysautonomia. The inflammatory signaling that happens with these infections is very complicated, and part of why they're so difficult to test for. The primary assumptions, which is that an infection is going to stimulate the immune system to make antibodies, and we are going to rely on those antibodies to determine whether or not that infection is active. That assumption doesn't apply with some of these low abundance chronic infections, because these organisms have evolved and adapted the capability of creating anti-inflammatory and immune disruptive signaling molecules as a response. So they can often confuse the immune system, which creates a very altered landscape of cytokines and other inflammatory mediators. And those can impact how blood flow to the autonomic nervous system is regulated. It can cause oxidative damage to autonomic neurons. And then, of course, that gets complicated quickly if we add environmental toxicants like mycotoxins from mold and toxic metals and organic chemicals and things like that. So the short of it is I do frequently see dysautonomia with chronic infections, especially when there's several infections present and environmental toxins. And our approach is to not only address those contributing factors, but to actually restore regulation to the nervous system. And depending on where the damage is, that can look different from person to person.
And you mentioned molds. How common is it for people to have molds when dealing with these infections?
Arguably extremely common in my experience. And so I often use the analogy of the overflowing bucket. anything toxic, inflammatory, infectious, or traumatic, both physically or psychologically, which are not ultimately separate in terms of the effects they have on our physiology, gets added to the bucket. And when we start to see the bucket getting close to overflowing and actually overflowing, that's when we see symptoms. And that's when we tend to see chronic illness that isn't responding to conventional symptom-based management. And so more often than not, I would say the folks who have the more severe non-responsive cases to cases of vector-borne infections have unaddressed environmental toxicity. And they may have genetic factors that influence how quickly they're able to metabolize those things, or they have an ongoing exposure that they don't know about, or they thought they were fine until they moved to a moldy apartment or something like that. And that's what kind of overflows the bucket. And then they find out that they actually had Lyme. In fact, I was just seeing somebody about a month ago, maybe 3 weeks ago, actually, who had chronic Lyme, knew she had chronic Lyme, was doing treatment in Mexico, stem cells, ozone, those kinds of things, and just thought her Lyme was flaring, but found out that it was actually a severe mold problem in her new apartment. And so now we're working on detox and things like that. But it oftentimes is the obstacle that people don't realize is still there. Even just a couple of days ago, I was talking with somebody who I've been working with for a while, and we were going down the Bartonella rabbit hole. We assumed that mold was already dealt with because she had already worked with a provider who had done detox therapies. But we found that there were still significant levels of mycotoxins in all of the classes of them in the urine. So there was still either some ongoing excretion going on or colonization of mold in probably the sinuses or the GI tract, and it hadn't been addressed. So it's difficult both for the practitioner and for the patient to try to parse these things out and figure out, okay, well, people always want to know what's making me sick. Is it Lyme? Is it Bartonella? Or is it mold? And it's yes. It's like, okay, to some extent, it's how these organisms and toxins have dysregulated the immune system, dysregulated mitochondrial energy production, and dysregulated the nervous system, and then how all of that can affect hormones, the gut, other organ systems. And we often have to repair and support those organs in their function while also addressing the things that are triggering the imbalance in the first place.
Yeah, since it's so prevalent, do you do a urinary mycotox test on everybody, or do you just, it depends on their history, and if you suspect that there might be a mold problem, that's when you have them do a urinary test for mycotoxins?
Yeah, so similar to with the specialty testing for vector-borne infections, none of these tests are perfect. So we have to think about their limitations. And I always, am transparent with patients about that okay, urine mycotoxin testing is one way we can determine if there are elevations in mycotoxins coming out of the body. But because it's only measuring what's coming out of the body, we don't currently have blood mycotoxin testing available, although I'm told it's being looked at. Food can affect it if there are foodborne molds. Also, the rate of excretion, which depends on how able a person is to detox. If we're going to see those levels high. People always want to know, well, does this tell me that there's mold in my environment now, or does it tell me that it's from a previous mold exposure? And we don't know that. We just know that it's coming out of the body. So usually my approach to mold assessment in a patient is to have them do a screening. Can I mention specific labs on this?
Sure.
Do a screening home test kit, like a self-collect dust sample through EnviroBiomics. I like the Actino plus Hurts Me Too. Hurts Me Too looks for mold. It's like an ERMI, but a little bit more refined. And the Actino looks for a bacteria that is associated with water damaged buildings that some of the newer research suggests may be more responsible for chronic inflammatory response syndrome or sick building syndrome than the mold itself. But it does not produce mycotoxins, at least not to my knowledge. So they're looking at slightly different things, but test the home and test the patient. So a screener like that, if that comes back positive, I try to get them to have an inspector come out who's sufficiently trained. And there's quite a bit of debate on what criteria are needed for an inspector to really be trustworthy in that regard. And then also, I might think about doing a LabCorp or Quest blood panel looking at the chronic inflammatory response markers, which are immune markers that tend to be dysregulated in mold illness. If budget allows, I'll also do a nasal culture for antibiotic-resistant staph, which is associated with water damage building exposure, and it'll look at it'll do a fungal culture as well, and then maybe an organic acid test, which is a urine test, but it will tell us if there's GI colonization of mold. And by colonization, we mean there's actually living mold spores that got in and created an infection in the area, rather than just inhalation or ingestion of mycotoxins without there actually being living mold. So the diamond approach would be test the home urine mycotoxins, test the sinuses and or gut, and then look at how the immune system is behaving. And usually if we get, 2 or 3 or even 4 of those things, it gives us a clearer idea of where we need to be focusing our energy.
And then how about Lyme? What are your favorite labs to look at Lyme, Bartonella, Babesia, other vector-borne infections?
Yeah. So I still prefer Igenics for Lyme. It's reliable. I haven't seen a lot of false positives with it. The other ones that are testing for Lyme, people often ask me about Vibrant Wellness, given the low cost. I have not found this to be a particularly sensitive test, which is, maybe a point of contention with some. I've talked to other colleagues in my profession who find that test to be fine. But in my experience, I've done split sampling before with patients who could afford it, and done either Igenics for Bartonella or Galaxy Diagnostics for Bartonella. And we found it on those and did not find it on Vibrant. So I usually use and Igenics just came out in the last, I think, year and a half with a Babesia immunoblot that I have found to be quite helpful. And so currently I'm using Igenics for Lyme, Babesia, and tick-borne relapsing fever, and using Galaxy Diagnostics, which was co-founded by a lot of the veterinary researchers on Bartonella right now, and I'm using that one for Bartonella.
What
You
do you
mentioned
like?
MDL. That's a decent screener as well. I just have less experience with that one. Yeah.
Yeah, with MDL, that's when I was diagnosed with chronic Lyme, I actually worked with a Lyme literate practitioner, and I was mentioning Igenics because that's who I was familiar with, but then she mentioned medical diagnostic laboratory. She's like, let's do that. It's less expensive and it may not pick it up, but it might. And if it does, then you could save the money. And I'm like, okay, I just listening to her advice, and it did pick up, picked up chronic Lyme as well as Bartonella. And but yeah, Igenics is the most well-known lab when it comes to those. And what do you think makes why do you prefer Igenics? I know they test for different species, I believe, of Borrelia. I don't know if it's the same with the other vector-borne infections. Is it just because they look deeper than just the antibodies themselves, the comprehensiveness of the test?
It's hard for me to, I don't have a lab science. I did, was an undergrad chemistry major, but I don't have a lab science background. So I'd have to, really get into the methodologies that they're using. I've just found that it's a relatively low false positive rate. Of course, there's always going to be false negatives that we have to think about. Like, is it missing an infection? And if suspicion is high, the International Lyme and Associated Diseases Society, or ILADS, still recommends that these are clinical diagnoses rather than laboratory diagnoses, meaning if index of suspicion is high and other conditions have been ruled out, you still want to treat them. But that and as well as just talking with other professionals who are Lyme literate physicians, it has stood the test of time. They continue to refine their approaches, like by adding new tests, but they don't seem to be, in my experience, just chasing bells and whistles. I don't do PCR through them. I just do the immunoblot, which is a more sensitive Western blot for Lyme, as well as the Babesia immunoblot. Bartonella, I've seen it miss it a couple of times, which is why I've been using Galaxy. I use their antibody test, the IgG immunofluorescent assay, which is about $500 or $600. So it's about the same cost as the individual infections on Igenics, but it gives you a titer, it gives you a number, which I like. So if you see it as borderline, you may be interpreting that a little different than if you see it as maxed out to the maximum dilution. And then you will see those numbers come down with appropriate treatment.
So a lot of people listening to this have Graves or Hashimoto's. Have you seen a relationship between these vector-borne infections and autoimmunity, whether it's thyroid autoimmunity or other autoimmune conditions?
Yeah, empirically and clinically, yes. Like I said, the data varies on which organisms are associated with what in terms of autoimmunity. But essentially, the way I explain it to patients is the concept of molecular mimicry, which is that there is a molecular structure or protein on the bacterial cell wall or cell membrane that looks structurally very similar to the proteins on our own cells. And if a battle ensues between the immune system trying to get rid of the organism, there can be priming of the immune system to react to very similar molecules that it may see in the wild, so to speak, aka in the rest of the body. And so the immune dysregulating the immune dysregulation that we tend to see in autoimmunity is often activated initially by an infection or a toxin or both. And so when we're thinking about autoimmune thyroid disease specifically, I'm almost always having a conversation about vector-borne infections, opportunistic viral infections like the herpes viruses, COVID. I've seen some Hashimoto's specifically, following COVID, as well as mold and heavy metals, because we know mercury can be, thyroid toxic.
Yeah, quick question with viruses. Would you consider Epstein-Barr to be like more like a stealth infection when it comes to viruses, or?
Good question. So the herpes family of viruses is a large family. It includes, herpes simplex 1 and 2, which are the viruses we typically think of when we, hear the word herpes virus. But the virus that causes chickenpox and shingles is also in that family, as is Epstein-Barr virus and cytomegalovirus, as well as a few others. One of them that's often tested for is human herpes virus 6 or HHV6. I consider these to be opportunistic infections. What that means is they're fairly ubiquitous. About 90% of adults have been exposed to them and produce antibodies to them. But under normal, healthy conditions, the immune system is able to keep them in check, and we don't seem to have major problems. But when the immune system is compromised, either from a more primary infection, like the ones we're talking about, environmental toxins, or just being in fight or flight all the time, whether that's from PTSD or a chronic illness and not getting answers, the medical trauma of living with these conditions, we tend to see a lot more reactivated and chronic herpes viruses. I see a lot of providers going and trying to play whack-a-mole with these infections, and to some extent, people can get transient relief. But oftentimes, if they're persistently activated and we're not seeing those antibody levels come down on blood testing, there's something more primary going on and needs to be investigated for.
All right. Well, thanks for sharing that. And if you could talk now about some of the treatments that you prefer for these vector-borne infections, and then like related to that, you mentioned like with Bartonella, you'll see like the titers go down, and I'm guessing the same with the others. So I guess the second part to the question: can you get rid of these permanently? Are these like Epstein-Barr, and where you're always going to have it, or is it possible to permanently eliminate Lyme, Bartonella, Babesia from your body?
I am skeptical that we can entirely eradicate these infections permanently, in the sense that we're not going to see eradication, but then they, return later at another time. And that's not the goal that I communicate to patients. It's a great question, though. I think that was asked, and I think I've talked about this in the past as well. But the goal is to promote more of a harmonious, it sounds hippie to say this, a harmonious relationship between the immune system and the other microbes. But essentially what we want to do is restore appropriate immune signaling, or promote more immune regulation, where it responds as needed to an acute infection, but is less reactive in an ongoing sense to organisms that may not be causing active problems. And I'm saying that kind of overly simplifying the Th1, Th2, Th17, T regulation, regulatory T cells, different branches of the immune system that have different, jobs in all of this. But if we can marginalize the infection, if we can get the relative burden of it down to the extent that the immune system can pick up the slack and do what it's supposed to do, we tend to not see as many problems. I've often said that if we had enough money to screen, 2 million people in the general, population who are asymptomatic for these infections, we would probably find positive results in several of them who were not sick. And so, when we're starting to see problems in terms of chronic degenerative disease or complex chronic illness, it tends to be when the immune system has multiple insults that it's trying to deal with at the same time. So restore immune competence, regulate the nervous system, and marginalize the infection as the goal, the primary goals, as well as correcting any damage that these infections may have caused by activating the immune system in the way that they do.
Okay. And then treatments, to use a combination. You mentioned earlier antibiotics, but I'm guessing there's other things you use. I don't know if you use herbs, there's ozone. So yeah, if you could
Yeah.
talk a little bit about that.
Yeah, so I highly individualize it. When I was trained, Dr. Kunkel used a lot of prescription antibiotic therapy, including IV antibiotic therapy, along with the best of what naturopathic medicine has to offer, which I always joke that my last name Plante was fitting for going into really using a lot of herbal medicine. But I love plants. They're incredibly useful in that they tend to be a little bit more sparing of the good microbes. And tend to be, broadly acting. So they have a lot of coverage against a variety of not only vector-borne infections, but several of them are also antifungal. So if there's opportunistic yeast overgrowth, many of them are also antiviral. And so if we don't entirely know what we're treating, or testing is cost prohibitive, or it's just really complicated, I will often, rely more heavily on the botanicals. But the best results that I'm seeing are when there's a combination. So if a patient can tolerate prescription antibiotics, I will use those alongside herbal medicines, as well as trying to correct the underlying immune signaling, promote adequate detoxification, and die-off support. And then if hormones and other systems are impacted, we target those as well. In my current practice, we don't do IV therapy, at least not in the Orange County location. But in my previous offices, we did quite a bit of IV therapy, both nutritional. So you can use, this is a little bit more for viruses and for cancer, but high dose IV vitamin C is an oxidative therapy that has an antimicrobial effect. We did a lot of IV ozone therapy, including EBU, or extracorporeal blood oxygenation and ozonation, which is where you take blood out, you ozonate it, and you put it back in, continuously. Although people have often done like the 10 pass as well. I do find ozone to be helpful. I don't think it's a miracle. It won't do all the heavy lifting, but it can be very helpful. The one that I'm probably one of the most passionate about is methylene blue, whether oral or intravenously. Although there's a lot of cautions to be mindful of if you're doing it intravenously. But I like it because it has a mitochondrial regenerative effect. It enhances oxygen utilization by the mitochondria. It is also neuroprotective, which many of these patients affected by these infections have neurological symptoms as well as complications. And it can enhance. It's a monoamine oxidase inhibitor, so you get more serotonin, more dopamine, and more norepinephrine. So brain fog, depression, anxiety, those kinds of things it can be very helpful for. And it tends to be a little bit gentler on the good microbiome. I call it a prescription antibiotic, but it doesn't really fit into the classic categorizations of antibiotics, like doxycycline and clarithromycin. And we can talk specific regimens too if we want to. But I'll use a variety of tools tailored to what the person can tolerate and what they need. But the best results I'm seeing are a combination of prescription antibiotics and herbal antimicrobials.
So you said with the methylene blues, you recommended, did you say IV or orally or?
It can be administered IV. You have to be, very careful of its serotonin effects when it's administered intravenously. I think if folks are on prescription antidepressants that interact with serotonin or other medications that raise serotonin levels, if you do either oral or IV methylene blue, you can cause serotonin syndrome, which is a toxicity caused by too much serotonin in the brain. But IV, the risk is much, much higher. Like if that was being administered in the hospital for a non-antimicrobial purpose, but for something else, you have to be off antidepressants for several days, to minimize that risk. So I'm always cautious about that with folks, but I have done it, and it can have a pretty potent effect. It's potentiated by red light. It's a photosensitive molecule that becomes more oxidative when exposed to red light wavelengths, and so there are some devices that shine red light on it or on the we actually used some at my last clinic where we had it was like a wristband that shined red light on your wrist, as the IV methylene blue is being dripped into the other arm, with the idea being it activates it on the inside. And it's a lot more potent intravenously, both therapeutically and with the risks.
And I know everybody's different, but like on average, how long is someone taking the methylene blue for if they're taking it, I guess, either orally or maybe not as long with the IV since it's more potent?
Yeah, so with oral, I'm typically averaging around 6 months, sometimes longer, sometimes 9 to 12 months, sometimes shorter, depending on how they're doing. It will it will turn your urine blue. I've had some folks say that their toilets got stained, but I've only had a handful of folks over the years report digestive upset or urinary pain, which prohibited us from continuing with it. But in many cases, it's very well tolerated, and we don't tend to see the GI side effects that we might see with prolonged oral other antibiotics, more classical antibiotics.
So I know you got to go soon. So, but I do want to ask you, like, what are some of your favorite plant-based, like your favorite botanicals that you use for these infections?
Yeah, so what I will often do is start with a broad spectrum formula like biocidin, which has a variety of botanicals in it. It's a mild biofilm disruptor as well. It's often not sufficient, but it's a good place to start because it kind of breaks up a little bit of that biofilm, but not in a way that really flares people the way that I see with the more phase 2 biofilm disruptors. And it has broad action. The one that has been shown in the research to be the most potent against multiple vector-borne infections is Cryptolepis sanguinolenta, which is I believe it is like a West African shrub. But that one can be a little bit herxy for some patients, meaning they can experience more significant die-off symptoms. So I don't usually start with that one. I usually start with, like I said, biocidin or something like Japanese knotweed, which has also been shown to be effective against all three. I think LymeDisease.org just recently published a post on I think it was a research article that they were citing that actually made this chart where they looked at, according to the research, what was effective against stationary phase Bartonella and Borrelia, Lyme, as well as what was effective against Babesia. They didn't differentiate between the different phases of Babesia. And you look at it and you're like, okay, well, methylene blue has activity against all three. Japanese knotweed has activity against all three, and so does Cryptolepis. I like Japanese knotweed because it has resveratrol and other anti-inflammatory molecules in it. So the die-off symptoms tend to be a little bit more mild. What I see more with that one from a side effect standpoint is nausea, particularly at higher doses, like encapsulated versions of it. Houtinia is another one, has activity against Bartonella, Lyme, and viruses, the herpes viruses. That's a traditional Chinese herb. Chinese skullcap can be helpful as well. Those are the main ones that I'm relying on. Cistus incanis, which is rock rose. That's kind of a fun one that less folks are familiar with. It's very, very broadly antimicrobial. So if somebody's just kind of dealing with viruses, yeast, tick-borne infections, a little bit of everything, you can make that as a tea it's a traditional Mediterranean herb that was used to as like a to keep people's teeth clean, and it has like this wonderful floral flavor to it. So that's another one. It's often used as a preventive. I think Dr. Kunkel, when he lived in Maine, would drink that as a tea every day to prevent infection. But those are just a handful of them.
Yeah, just curious, do you have any experience using homeopathy?
You know, I was trained in naturopathic medical school, you know, with some, you know, by classical homeopaths, but I'm using it a lot less in my own practice. It was just where I did residency, we hardly did it at all. It's one of those tools that I really wish that I knew more about how to expertly, particularly constitutional or classical homeopathy, but it requires quite a bit of effort to get proficient at. I have had some folks report that Desbio was helpful, which I think is homeopathic in nature, as well as, you know, some of the no-sodes, which are diluted forms of the microbes themselves. I have a little more experience with low-dose immunotherapy, which is, in my opinion, a little bit of a cross between vaccines and homeopathy. But that's the extent of it.
Yeah, you mentioned Desbio. I actually took some of their products when I was dealing with chronic Lyme and Bartonella. So
The best things I've
before
heard
we
are with their viral oh, sorry about that. Their viral protocol is apparently pretty good.
Yeah, they have for Epstein-Barr and cytomegalovirus, I think even parvovirus and herpes simplex. Yeah, so they have a whole line against all these different viruses and vector-borne infections. So before we wrap it up, is there anything else that I should have asked you that I didn't ask you? Anything else you want to wrap up with?
I think what I would say is, you know, a lot of folks are asking the question about like what is long haul COVID and kind of what's going on with that. And we could do a whole talk on that, and we won't. But what I often find is folks have undiagnosed and untreated vector-borne infections and or environmental toxicities. And that's what's causing the bucket or the cup to be close to full before they got COVID-19, or I've had a number of folks, you know, post COVID-19 vaccination experience symptoms of long haul COVID. And of course, there are approaches that are more specifically targeting the spike protein and issues with that. But more often than not, I'm seeing untreated other infections. And so if you're struggling with long haul COVID and you're working with an integrative provider, you know, don't hesitate to bring up the question of whether or not vector-borne infections could be influencing what your immune landscape is doing and why it's responding so significantly to COVID or to the spike protein.
All right. Well, you shared a lot of valuable information. And where can people find out more about you, Dr. Brian?
Yeah, so if you go to our Amen Clinic's website, you can find me. You can also just Google me, Brian Plante, ND. I'm not super active on social media. I do have pages, but I'm not super active. So if you'd like to reach out and, you know, get some support, I do, like I said, do some health coaching, you know, out of state. Currently only licensed to work, you know, deeply with patients in California. But if folks have outside providers they're working with, I will often, you know, act as a consultant, which, you know, tends to work well if they're able to manage prescriptions. So be happy to support you, and I'm hoping to put more content like this out there. So stay tuned if you're interested in learning more about these topics.
All right. Well, wonderful. Well, we'll make sure to put those any links, the ones you mentioned, to your website and all that in the show notes. And again, thank you so much. You shared a lot, and you know, I learned some things as well, and I'm sure my listeners did too.
Thank you so much for having me.